So for oh yeah, so for people who don't know me, my name's Iona, and I'm a fifth-year intercalating medical student. And we're going to be talking about the GI system today. I have an understanding that you guys have an end-of-year mock, end-of-year test on Friday. So I've geared it up to be kind of as exam focused as possible, and like how to answer GI questions as well as like the topics as well. So kind of what we're going to talk about is top tips that I thought of that are really helpful for answering GI questions specifically. And then all my teachers are going to be through these 3 cases. So I'm going to kind of get you guys involved as much as possible through the chat, answering some questions I have about these cases. And then from the cases, I'm also just putting a few other diseases that I just think come up all the time in exams. And then I've got a little quiz at the end because I heard you guys like MCQs. And I think questions are a really good way to learn anyway. Okay, this is so bright. Okay, so my first top tip is learn your sites. So especially for GI, your abdomen is split up into either 4 quadrants or 9 sections. So so you've either got your right and left, upper and lower quadrants, or you've got your 9 sections. So you've got your right hypochondriac, left hypochondriac, epigastric, and then you've got your right and left lumbar regions, or they're also called your flank regions, your umbilical region, and then your right and left iliac regions, and then your hypergastric region, which is also called your suprapubic region. I'd really, really recommend learning your sections. And then also, as you can see by the picture, learning kind of what is underneath each section, because in a lot of questions, they'll present, it'll be like an X-age person presents with pain in the epigastric region, for example. So if you know epigastric, you can kind of know the organs that are there. So epigastric is mainly your stomach, as you can see by the picture. And then it's also your duodenum and your pancreas. So if you hear epigastric, you should be thinking things that happen in the stomach, so gastritis, things that happen in the duodenum, like peptic ulcers, and things that happen in your pancreas, like pancreatitis. So I'd really, like, top tip, just write down each of your sections and then write down like 2 or 3 things that come out of each section. So I would say, like, right hypochondriac region, you've got your liver, so like hepatitis, and you've got your gallbladder, so cholecystitis, and that's like my 2 things for that region. Left hypochondriac region is your spleen, so splenic ruptures, splenic infarcts. Then your lumbar regions, or your flank regions, that's where your kidneys are. Umbilical region is, you've got your aorta, but nothing really that special in the umbilical region. Right and left iliac regions, so your right iliac region, you have classically your appendicitis in your right iliac region, and you also have this thing called your ileocecal valve, your ileocecal junction. So that's where your small intestine meets your large intestine, and this is where Crohn's attacks mostly. So that's where you get Crohn's as well as in your right iliac region. Hypergastric is where your bladder is, so think like urinary tract infections, cystitis. And then left iliac region is where your sigmoid colon is, so like diverticular disease, sigmoid volvulus. And then also you have, like, in women, you have all the gynae stuff as well, but that's not something we're going to talk about in this course. But generally, remember your regions and remember a couple things that come from each region, and it will help you so much for exam questions specifically, not necessarily in real life on the wards, but exam questions specifically. And then my second tip was learn your signs. So kind of like your sites, your signs are quite rare, and they don't come across a lot in patients, but they come up a lot in exams. So they're really, like, for the amount of time you spend learning them, they come up a lot. And these are the ones that I've taken from your lectures. So these are the ones you would get asked on in exams. And then I've just put in bold the ones that I think come up the most and are kind of the most clinically relevant. So the first one I put is Murphy's sign. So this is a sign of gallbladder inflammation, and how you elicit Murphy's sign is if you put your hand just below your right rib cage and then you kind of press, that's where your liver is. And if you get a patient to breathe in, then what happens is your gallbladder goes down and it goes over your hand, and if your gallbladder is inflamed, then it's painful, and this will elicit pain. So that's Murphy's sign, and that's a sign of gallbladder inflammation. So that could be gallstones, cholecystitis, or any kind of gallbladder disease. And then you have McBurney's point, which is where appendicitis happens. So that's the site which is in the picture on the top right. So that's where you're most likely to feel for appendicitis. And how you get there is you go to the umbilicus, and then you go to the right iliac crest, which is like the bony bit on your hip, and you go 2/3 from the umbilicus to your right iliac crest. In exam questions, sometimes they do a thing where they kind of try and trick you. So is it 2/3 from your right iliac crest, or is it 2/3 from your umbilicus? So remember, it's 2/3 down, not 2/3 up. So it's 2/3 from the umbilicus to the right iliac crest. And then the other ones I thought were Gray-Turner sign and Cullen sign. So they are essentially the same thing, but in different places. So they're ecchymosis, which means bruising, and they're sign of really, really bad pancreatitis. Like if you see this, a patient is very, very ill. So it's basically bruising, and Cullen's is bruising periumbilically, so it's round the umbilicus, and then Gray-Turner is on the flank, so it's on either side. And this is how I remember it, is Cullen's is like one word, so it's in the middle, and then Gray-Turner's is like on the either side, because it's like Gray-Turner's, it's 2 words. But if that works for you, works for you, but if it doesn't, that's fine. And then I'm going to start with some cases. So I would really like you guys to get involved in the chat if possible. So I haven't given you very much information on purpose. So this person is a 54-year-old man who presents with pain after eating, especially large meals and spicy food. His pain's in the epigastric region, but I haven't told you anything else. So I'm hoping that people will get involved in the chat and ask me some questions. Is there anything else you want to know about this person? Any other questions you would ask him if you were seeing him in, like, on the ward, for example? I don't actually think I can see the chat. Millie?
Hello.
Could you read me out any answers if they're on the chat?
I can do indeed.
I can't see the chat because I'm sharing my screen and I'm on, yeah.
Someone said, when did his symptoms start?
Oh, I can see it now. Okay, his symptoms have been around for about 3 months and they've just kind of slowly got a bit worse. Anything else anyone want to know? Good question, by the way. Any brave people? What about the pain? Like, oh yeah. Any history of liver or gallbladder issues? No, not especially, no. Does the pain radiate anywhere? Good question. No, it doesn't. It can sometimes go up a little bit into his chest, but not anywhere else. How long do the symptoms last for? E.g., is it intermittent? Yes, so it's only kind of around meals, and especially when he has large meals, and especially at night. And he doesn't really have it in the morning. He doesn't really have it when he's not eating. Does he consume spicy, greasy food or drink alcohol quite regularly? Yes, he does. Any change in bowel movement? No. Does the pain occur when he's lying down? Yeah, he knows that sometimes when he's asleep or when he's about to go to bed, when he starts to lie down, then it kind of gets a bit worse. That's a really good question. And then, so does anyone want to guess any differentials for this man?
And what does differentials mean? Sorry.
Yeah, fair question. So differentials it means like potential diagnoses. So you don't want to like hone in and say this man's definitely got this thing, but a differential is like your options of what you think it might be. So normally, like, people will ask you what your top 3 differentials. That means like, what are the top 3 diagnoses you think are the most likely? Does that make sense? Cool.
Yeah, thank you.
Yeah, a lot of people saying gourd. That's a very good answer. Anything else apart from gourd that you think it might be? You gotta have 3 top differentials on a ward round. The surgeons might shout at you. Think what I said about epigastric pain. So you've got other things in that area other than the stomach. Gourd is a good answer though. I will give you that. Yeah, good. Gastritis. Good. Okay. Yeah, duodenal also as well. That I'd say that's, yeah, good. Yep. I think that's my actual total list of everything that I said. Yeah, good. So you got gourd, you got gastritis, you got H. pylori. Cholecystitis as well is a good shout. So it's not technically in the epigastric region. So like for exams, that would make it less likely, but in real life, that would be a pretty good guess. and duodenal ulcers as well. That's a good thing as well. You missed out malignancy. Always worry in someone that's like a bit older, something that's a bit more sinister, but you got like all the important things. Let me just move the chat. Yeah, so I asked kind of similar questions. So how long have you had the pain? Maybe talk a bit more about the pain, describing the pain, Socrates, so site onset, character of the pain, radiation of the pain, associated features of the pain, time, so how long does it come on for, exacerbating factors and severity. So like maybe ask a bit more about the pain, and then also I said maybe ask about constitutional symptoms. So this means like generic symptoms that are a bit indicative of something more sinister. So like weight loss, fatigue, muscle pains, joint pains, all a bit like, they're all a bit non-specific to a specific system, and they're generally associated with things like malignancy. Just to rule them out. I didn't think this person had malignancy, and that's not where it's going, but always have that in the back of your mind. So good differentials. Remember, just as gastritis, you can also have esophagitis as well. That's the only one you missed, but good. Okay, so now I'm going to talk a little bit about GORD, H. pylori, and zollinger ellensen syndrome, which I think are three things that come up a lot in your exams. So yeah, GORD, gastroesophageal reflux disease. So it's inappropriate relaxation of your lower esophageal sphincter. So as you can see in this picture, you have your upper esophageal sphincter, which kind of separates your pharynx from your esophagus, and then you have your lower esophageal sphincter, which separates your esophagus from your stomach. And your stomach is very acidic, so if you have inappropriate relaxation of the esophageal sphincter, it allows for acid to reflux back from the stomach into the esophagus, and the esophagus is not equipped for this, so it can cause a lot of irritation of the esophageal lining, and that's what you get this pain and this burning sensation from. So risk factors are anything that causes like an increased weight around your stomach, because that naturally pushes your stomach up. So BMI and pregnancy are kind of risk factors for the same reason, because they both cause an increased intra-abdominal pressure. And then also smoking as well as a risk factor, and also being a man. And then things like spicy foods, alcohol, eating late at night, eating large meals, as well are kind of very modifiable risk factors that you can change that you can give kind of lifestyle advice for people if they have these symptoms. So when would you get worried in someone who had this? So if they had any constitutional symptoms, like I said before, so any signs of weight loss, you'd think that people with GORD would lose weight because it's uncomfortable to eat, and this pain is associated with eating. But actually, we don't see that. We don't see a lot of people losing weight with GORD. I think it's just because it's not so bad that people kind of push through and people still want to eat, that it's kind of okay. So weight loss is a good indicator for something a bit underlying, like another cause for gastritis. Anemia maybe shows that this person is bleeding from something, so maybe there's an underlying cause that's causing them to bleed, like an ulcer. Dysphagia, so difficulty swallowing, that may be sinister of a cancer. New onset dyspepsia, if they're older and they have dyspepsia, that's a bit rarer. And then also symptoms that are refractory to treatment. So that's like if you've given them a dose of, say, a PPI regime, and then it comes back, maybe there's an underlying cause, and maybe that's something to be looking into. Okay, so another question is, there's one long-term complication of persistent gastric reflux on the esophageal lining. Does anyone know what it is? Yes, good. Well done, Charlotte. Barrett's esophagus. Good. So, like I said, the esophageal lining is not equipped for this acidic environment. So, the esophageal lining is made up of this squamous epithelium, which is very thin, and it's not very robust epithelium. So, in response to kind of this continuous acid reaching the esophagus, it needs to kind of adapt to it to become more robust and strengthen the lining so it doesn't rupture. So how it does this is it turns into columnar epithelium. So remember this, because it does come up a lot in your exams, and it's squamous epithelium originally, and then it becomes columnar epithelium. And that's essentially it. And people who have Barrett's esophagus, it's quite rare, but sometimes it does turn into an adenocarcinoma. So it's classed as pre-malignant Barrett's esophagus. And people with Barrett's esophagus, they normally present with like an acid reflux kind of picture, and then they might have a camera down like an OGD and then that finds Barrett's esophagus. And once you've been diagnosed with Barrett's esophagus, you need a continuous OGD to make sure that it doesn't become an adenocarcinoma. So remember that if you have cancer of your esophagus, it's normally a squamous carcinoma, because that's what the esophagus is. But if people have Barrett's, then it's actually turned to columnar, so it's not a squamous cell carcinoma anymore, it's an adenocarcinoma, which I think is interesting. And then we're just going to touch on H. pylori. So H. pylori is a really nasty pathogen that affects your stomach, and it can present with a lot of symptoms of GORD. So it causes superficial gastritis of the stomach lining, and it affects the stomach in different ways depending on which part of the stomach is affected. So if you have if it affects diffusely your stomach, you get kind of a mild gastritis, or most people are asymptomatic. And this can kind of be a bit worrisome, because then they'll have it for a long period of time because they haven't been symptomatic and they haven't been bad enough to go to the doctor. But so then the other two, or if it affects the proximal part of the stomach, this causes an atrophic gastritis, and this is the one that very rarely but is possible to turn into cancer. And if you see the picture on the left, how H. pylori helps kind of the stomach turn into cancer is it starts as cascade to superficial gastritis, and then once that cascade has been started, it goes down the path of atrophic gastritis to metaplasia to dysplasia, and then to finally to adenocarcinoma. So that's the proximal one is most likely to cause the cancer, and then the diffuse one, the distal one, is most likely to cause peptic ulcers. So that's the one in the antrum of the stomach and also the duodenum. That's low cancer risk, but likely to cause peptic ulcers. And then so H. pylori management is also really important to know. So the most common way to diagnose it is your carbon-13 urea breath test, or you can also use a fecal antigen test. And most of the time people do it straight after presentation. The really important thing is to know you shouldn't be taking any PPIs when you have a H. pylori test. You actually shouldn't have taken PPIs for 2 weeks, because they can cause a false negative. And then really, really important to know is how you treat H. pylori. So it's treated by triple therapy. So triple therapy is 3 things. So you have 2 antibiotics and 1 proton pump inhibitor. The proton pump inhibitor can be literally absolutely any proton pump inhibitor you fancy. It can be omeprazole, lansoprazole, pantoprazole, rabeprazole, any one you fancy. Antibiotics are amoxicillin and clarithromycin if someone is not allergic to amoxicillin. If they're allergic to amoxicillin, then metronidazole and clarithromycin. So amoxicillin, clarithromycin, omeprazole, or metronidazole, clarithromycin, lansoprazole. Okay. So another cause of gastritis this is really, really, really rare, but again, comes up a lot in your exams, is Zollinger-Ellensen syndrome. So it was actually discovered by 2 Liverpool medics, which is why Liverpool really, really like it. And it presents as a triad. So it's a gastrinoma, so it's a gastrin-secreting tumour, and it most commonly affects the pancreas or the duodenum. But actually the local effect of the tumour isn't what people normally present with. It's normally this gastric hypersecretion. So it secretes gastrin, which stimulates excess acid secretion in the stomach, and that causes gastritis. And then the third thing in your triad, which is peptic ulcers. So you have the effects of the local tumour, and then you also have the effects of the gastrin secretion. It's mainly sporadic, so it happens, it's just a random mutation, or it's part of this thing called multiple endocrine neoplasia, which is a group of inherited disorders, which I don't think you need to worry about. But it basically means that if it's a part of this thing, it's called multiple. So if you have this, then you probably should look elsewhere for tumours elsewhere. And the treatment for it is give them high dose acid suppression. So again, like your PPIs or your H2 receptor antagonists, and then resect the tumour, so take it out. Does anyone have any questions so far? I'll move on to case 2. Just give you a 2-second break. Okay, so case 2 is a 25-year-old woman, and she has lower abdominal pain. Pain is in the right iliac crest region. What else would you like to know about this woman and her pain? Any questions about her pain? How long she had it for? What's her pain like? This could be a lot of things, so. Where did the pain begin? Yeah, it kind of, it's always been in the right. That's a good question though. Does it happen straight after eating or a while after? Yeah, I'd say a while after. I'd say like a couple, maybe 6 hours after eating. How would you describe the pain? I'd say it's like a crampy pain. It's quite sore. I'd say it's about a 7, and I'd say it's not just in the right, but it's kind of everywhere, but it's mainly in the right. I wouldn't say it radiates anywhere. I'd say that, does anything make the pain better? No, nothing makes the pain better. Sometimes going to the toilet makes it better, actually. Maybe ask me how long I've had the pain as well. How long has you had the pain? Yeah, I've had it for about 3 months, on and off. Oh, it's really bad now. So it comes and goes, but now it's really bad. Now I've come to the doctor. Okay, yeah, all good questions. So anyone want to guess some differentials for this lady? Appendicitis, good, yeah. Kidney stones, yep. Appendicitis, good. Anything else? I'm trying to think of some clues. Colitis, yeah, good. Crohn's, good, yeah, good. Ovarian cyst, yeah, really good. So always think about gynae stuff in women. I think they're pretty good. Yeah, well done. So yeah, again, other questions that I put was nausea, vomiting. How unwell do you feel in yourself? Do you have a temperature? Any signs of infection? And again, any constitutional symptoms? I guess that's just like systemic upset in this patient. So yeah, good. Whoever said Crohn's, Eleanor, very good. So that was my top differential as well, inflammatory bowel disease. I also thought maybe irritable bowel syndrome. That's quite common in young women. Appendicitis, definitely have to rule out, and especially because where it was, it does point you towards appendicitis, but the history was a little bit too long. And yeah, Irene, very good for pointing out gynecological disease. So remember, like, ovarian torsions, ovarian cysts, ectopic pregnancies in young women as well. Okay, so what is the difference between irritable bowel syndrome and inflammatory bowel disease? So they both present with quite similar symptoms. One of the main differences is that if you were to look at the bowel of someone with IBS, it would look completely normal. But if you looked at someone with inflammatory bowel disease, it would look very inflamed. So bowel syndrome is kind of a functional disease. So the intestine itself is not harmed. No one actually really knows what causes it. They have a lot of similar symptoms, so you get like diarrhea, mixed bowel habits. IBS classically has the feeling of incomplete bowel movements, so like you go to the toilet but you never feel like you've fully gone. That's a classic IBS symptom. IBS never presents as an emergency, and people are never systemically unwell with it, unlike IBD. And with IBS, there's nothing wrong with your absorption, so you don't tend to lose weight with IBS, but you do with IBD. So generally, IBS it can cause a lot of stress, and it can be very unpleasant to your life, but it's not kind of worrying, and it's not life-threatening in the way that IBD potentially can be. Okay, so the differences between the types of IBD come up a lot in your exam, so I thought I'd just talk about it a little bit. So IBD splits up into 2 types. So you have ulcerative colitis and you have Crohn's disease. So ulcerative colitis means your colon. So it affects only your large colon. So it starts at the rectum and it continuously works up all the way through the colon, and it doesn't go past what's called the ileocecal valve, which is what separates the large colon from the small intestine. Crohn's disease, however, can affect anywhere in the GI tract. So as it nicely says, it can affect gum to bum. So it can affect absolutely anywhere. It can affect your mouth, it can affect your esophagus, it can affect your large small intestine. And it doesn't go in this continuous line like UC does. It has these what we call skip lesions. So it can affect one part and then it jumps to another part, and it's unpredictable in the way that it goes. UC, typically the inflammation is superficial. So it normally, for this reason, it kind of affects the superficial endothelium. So it tends to cause a lot of more superficial bleeding. So people with UC tend to get a lot more bloody stools than Crohn's do. Crohn's has a lot more. It affects inflammation through all the layers of the bowel wall. So actually, it doesn't bleed as much, but it causes things like strictures and fistulas a lot more in Crohn's. And then I put a comparison table, but I think that's just something to look through in your own time. The main thing from the table is that the risk of cancer in UC is quite markedly raised, but the risk of cancer in Crohn's isn't so much. Okay, case 3. So this is a 37-year-old man who has sudden onset, very severe abdominal pain again in the epigastric region. So what else would you like to know about this man? When has it started? It just came on 5 seconds ago, just like absolute hammer came on. Any other questions? What was he doing prior to the pain of healing? Absolutely nothing. Just about to walk on the football pitch apparently, but absolutely nothing, like nothing significant. Has he felt it before? No, he's never had it before. That's a good question though. Does pain? Yeah, it does. It starts. It's in the epigastric region at the bottom, but it goes right to his back. Does anything make it worse? No, it's really bad, and nothing makes it worse. I'd say maybe he's been sick a couple times, and that's helped a little bit, but not really. How does the pain feel? Really horrible. So like you can see in the picture, he's collapsed to the floor because it's so painful. It's really, really nasty, like 12 out of 10. Any blood in the vomit? No, no blood. Good question though. Yeah, that's a really good question. Okay, does he smoke, drink alcohol? Yeah, he does actually. He drinks a lot of alcohol. That's a big clue. Okay, does anyone get any guess, any differentials? If you're stuck, think what's in the epigastric region. Yeah, good. Pancreatitis. That's good. Gastritis. Yeah, good. Gastric cancer. Yeah. Duodene also. Yeah, really good. Very good. I think what my other ones were. Yeah. So yeah, good, really good. Who asked about the alcohol as well? Serene, really good question. So yeah, again, asked about just how long you had it, how do you describe the pain, Socrates, nausea and vomiting. So the answer is acute pancreatitis. People with acute pancreatitis feel incredibly nauseous, and are often vomit. Constitutional symptoms, not so important, but always ask them. Good. So you want to, if you're thinking pancreatitis, you want to think about what's causing this pancreatitis. So the two most common causes are alcohol and gallstones. So good, ask about history of alcohol, any alcohol binges, history of alcohol abuse. Also ask about risk factors for gallstones, so previous gallstones. And there's 5 risk factors for gallstones, so they're called the 5 Fs for gallstones. So it's fair, which means fair skin, Caucasian, female, 40 or 50 years old, fertile, which means pregnant, and then fair, fat, female, 40 and fertile. Yeah. So they're your 5 Fs for gallstones. This man is not female, he's not fat, he's not pregnant, he's not 40 or 50, and he does have fair skin. But because of his history of alcohol, it's much more likely to be caused by alcohol abuse than gallstones. But you never know. Okay, so my differentials were acute pancreatitis, ruptured peptic ulcer, good. I put cholecystitis, cholangitis. And then I put the other 2 because he's clearly incredibly unwell. So bowel obstruction, perforation, mesenteric ischemia, they're the other kind of GI things that would cause you to collapse to the ground really, really unwell. So clearly this man has something significant. Whoever was thinking about vomiting blood with ruptured ulcers and gastric varices was also really good point. So before we talk about pancreatitis, just remember that the pancreas has your endo and exocrine functions. So your endocrine is about regulating the homeostasis of your blood sugars through insulin, glucagon, somatostatin. And then you also have your exocrine function, which is your digestion of food through your enzyme secretion. So like your protease, lipase, and your amylase and stuff like that. Okay, so acute pancreatitis is the most common causes, like I said, were alcohol and gallstones. But you have loads of other causes that are nicely laid out in this mnemonic called I Get Smashed. So so you've got alcohol, gallstones, you also have the Titius tritianus scorpion sting, you've got mumps, steroids, trauma, ERCP, and drugs. You've got a lot of other things you can think about. It's classic for severe sudden abdominal pain that radiates to the back, that's in the epigastric region. Absolute classic for acute pancreatitis, associated with nausea and vomiting, and collapse, if not loss of consciousness, just collapse because it's so painful. And then I put investigations of blood tests and imaging because that's really vague. I realize that's really vague, but there's so many things that can cause pancreatitis that you would kind of do a general screen for people, but then depending on your history, you might also do different things. So if you think someone has a history of alcohol abuse, then you're more likely to do things like a liver function test, for example, and look at their GGT to see if they haven't anything wrong with their liver that might say that they maybe drink too much. If you're thinking more gallstones, you do imaging. So you do an ultrasound of the gallbladder to see if there's any gallstones in the gallbladder or any in the common bile duct. And then your diagnosis for pancreatitis is you have to have 2 out of 3 things. So the 3 things you need are clinical history suggestive. You need an amylase, which is 3 times the upper limit of normal. So 100 is normally the upper limit of normal, so 3 times that is 300. And a CT scan showing inflammation. So you normally need 2 out of 3 of those things to be classed as having acute pancreatitis. And the management for acute pancreatitis is fluids, pain relief, no antibiotics. So you give fluids, normally crystalloids. I wouldn't worry too much about that though, just fluids is fine. It's incredibly painful, so don't be strict with your opioids. Give strong opioids as soon as possible. Don't give no antibiotics needed. There's no evidence to show that antibiotics actually help at all with pancreatitis, and it just it stimulates resistance, and it's not recommended anymore, with the exception if they are septic, which obviously makes sense. And then a huge part of management is also nutritional support in people with pancreatitis. And then my last thing that I'm going to talk about is pancreatic cancer. So as you can see on this picture on the right, the pancreas, the pancreas is made up of different parts, but the head of the pancreas, which is like the bulge bit, overlaps with the duodenum and the gallbladder. So overlapping with the pancreatic head, you have the common bile duct. So if you have a cancer here, and 70% of all pancreatic cancers occur in the pancreatic head, it can easily compress the common bile duct. So this causes a backflow of bile, and then people can get jaundice from this. And this is really important because the pancreas is retroperitoneal. So it's really far away from any nerve fibers, and it has to grow quite a bit to elicit pain from people. So most people present asymptomatically. Some people, if they're quite late stages, can present with abdominal pain, but the most common presentation is painless jaundice. So so they get jaundice from the compression of this common bile duct. And then they can also present with things like weight loss, but it's normally like weight loss, and it's normally like the weight loss and the painless jaundice that people present to hospital with. And this follows something called Courvoisier's law. So it states that a patient with painless jaundice and an enlarged gallbladder is unlikely to be caused by gallstones, because gallstones are incredibly painful, and therefore it is cancer until proven otherwise. It's very unlikely that gallstones that are constricting the gallbladder are going to be painless. So someone comes in with painless jaundice, you think cancer of the pancreatic head, or you think of cancer of the bile duct, so cholangiocarcinoma, before you think gallstones, even though pancreatic cancer is pretty rare. But investigations for it, so what you'd want to do is like generic blood tests, FBC, renal function, LFTs, clotting, bone profile, generic blood test, and then the calcium 99 is your specific blood test for pancreatic cancer. And then the other one is a fecal elastase, which is a fecal test, and that's also specific for pancreatic cancer. And then you want to get this person into imaging as soon as possible. So you could do an ultrasound, but ideally a CT or MRI. And that is everything my talk. Does anyone have any questions? I've got a little quiz prepared. We'll go on to that in a minute, but does anyone have any questions about anything I've talked about?
How do we because this is so useful. How do you access this PowerPoint afterwards? If you want to refer back to it when it comes to revision.
Yeah, no worries. I can send it to you. I can send it to Millie, and then Millie can send it to you maybe.
Yeah, if anybody does want anything, just let me know and we can send it out. It's going to go up on our YouTube channel as well, so it'll be available to watch whenever you guys want.
Oh, perfect. Thank you so much.
No worries. Just to point to people as well, I put the feedback link in the chat. If you could fill that out for Iona, we would all be very, very appreciative.
Cool. Thank you. Does anyone have any other questions about anything they weren't sure about? I'll just give you a minute. I'll give you a minute while I'm getting this quiz thing ready.